The 58th live webinar on orthopedic principles. And today we are going to discuss about scaphoid fractures, SLAC and SNAC wrist. We are back with our stellar faculty, Dr. Saurabh Agarwal from the United Kingdom. Over to you, Dr. Agarwal.
Yeah. Once again, Dr. Hitesh, I'm very grateful for your kind invitation and this opportunity. And thank you all for taking out your time today. So our topic today is scaphoid fracture, SLAC wrist, and SNAC wrist. So this is a fairly big and exhaustive topic. I'll try and simplify it as much as I can. So yeah, this is my hospital, Princess Royal, for those of you who are on live screen from India. I'm an upper limb surgeon, and sort of shoulder and hands is where I specialize. Right, so right, okay. So scaphoids. The mechanism of injury is hyperextension. That's very important, hyperextension, radial deviation. So what happens is, as you can see here, proximal pole is very snug in the fossa. It gets locked. Distal half of the scaphoid is free to move. And that's why sort of it keeps moving dorsally and there's a fracture. Other thing, if you're very clever and appreciate the anatomy of radioscaphocapitate ligament, it acts as a sling, and that's why you get that classical sort of a waist fracture. Now, other thing with hyperextension is, so this injury is going to be very common in footballers, goalkeepers, because when they catch the football, their hand goes into hyperextension, and this will happen. Similarly, linesmen in a game of football, or occasionally I will see spectators in a football match. They will come to me saying, "Oh, I caught a football in a match and I've got pain now," because again, classically hand goes into hyperextension, and then they will end up with a scaphoid injury. I'm not going to go into a lot more theory because, as I said, there's a lot to discuss here. Theory, I'm sure all of you guys know. Just very briefly, Herbert classification. Again, type A is stable fractures. So A1 is a tubercle fracture. A2 will be any incomplete waist fracture. Now B, B1 will be a distal pole. B2 is a waist. B3 is a proximal pole. B4 is transscaphoid parilunate injuries. Then there's also a B5, which is a comminuted scaphoid. And then there's a type C, which is a delayed union, and a type D, which is a non-union scaphoid. Important thing here is this classification does help you in the treatment. For example, if it's a B2, which is a waist fracture, which is displaced, then patient needs a surgery. All B3s need surgery, all B4 need surgery, B5 need surgery, delayed union and non-union will need surgery. So think of Herbert classification like that. It may help you to remember. So these are the few things which we're going to discuss in the coming few slides. Diagnosis, investigations, what are the indications to fix? Now this is an exam question. You'll be shown an X-ray of a scaphoid, and then you'll be asked what are the indications when you will fix a scaphoid fracture. So that's important. Techniques, approaches, and then immobilization, plaster immobilization. So we're going to see them in the next coming slides. Clinical diagnosis. Now, most important here is, what I want you to appreciate here is, it is an intra-articular fracture. That's very important. The reason being a hydrostatic pressure in the wrist. So whether you fix a scaphoid or manage it non-operatively, important is for you to tell your patients not to clench fist very hard, because when they are doing this, it generates a lot of hydrostatic pressure in the wrist. So that fluid tends to seep into the fracture site, and it will cause delayed union or non-union. And this is the reason in a non-union scaphoid, you get cis, like in a hip. So remember that point, it's an intra-articular fracture. Rest, you know where to feel on scaphoid tubercle and anatomical snuff box. Then in terms of other thing to remember is 1 in 6, 1 in 7 scaphoids initially will not show up on an X-ray. So if in doubt, if there's a localized swelling on the anatomical snuff box with pain, give your patients a plaster cast, a slab for 2 weeks, bring them back, do another repeat X-ray. Even then, if it doesn't show up, a patient is clinically tender, then you need to get an MRI scan. So in terms of investigations, let's start with X-rays and then we'll see what other modalities. Again, these next 2-3 slides are important in the sense, scaphoid, unlike any other bone, you need to get 4 views at least, not 2 views, 4 views. So which are those 4 views? So first is your PA wrist view with wrist in ulnar deviation. Like we were saying last Sunday, ulnar, PA view, not AP view. PA because ulnar styloid is the most ulnarmost structure in a PA view. And why ulnar deviation? Because that's when scaphoid is fully extended. Remember, it's a bean-shaped bone. And when it's fully extended, you can see the whole body of scaphoid. So if I were to give you one X-ray to diagnose a fracture, then it has to be a PA ulnar deviation view because you can see the whole scaphoid. Lateral view, you can't see a lot. As you can see here, scaphoid is superimposed on lunate, where you see the relation. All you do in lateral view is you see your scapholunate angles and the relationship of your proximal pole of scaphoid to your lunate. So if you have scapholunate ligament injuries, scaphoid will tend to come out dorsally. So you see that relation between lunate and scaphoid. 45 degrees supination. Now this is a very important view to see the proximal pole of scaphoid. So if you see carefully here, distal pole is all superimposed. I can't comment on distal pole, but I can see the whole proximal pole. Importance being when you put a screw in your theaters, you need to center your wire right here, if you can, in the sort of middle of your proximal pole. So this is the view you're going to ask for from your radiographer when you're fixing your scaphoid. Then 45 degrees pronation view. So now if you see here carefully, you cannot see the proximal pole. All I can see is sort of distal half of scaphoid. So unless I get a pronation view, I cannot comment on distal pole. Again, when you're putting your screws, this is the view you look for to center your screw. And this is the view you look for and ask for in theaters to make sure your screw is not prominent distally. So pronation views and supination views. And I'll keep harping on that as we go along and we see more X-rays. So yeah, so one is X-rays, then MRI. So as I was saying, at 2 weeks, if patient is still tender, you carry on with plaster cast, and you ask for an MRI. The reason being MRI is 100% sensitive. And even if there's no fracture, there's just edema, like an incomplete waist fracture, it'll pick up. Other advantage of MRI is scapholunate ligament injury. So with hyperextension injury, you can either damage your scaphoid or rupture your scapholunate ligament. And clinically, it's very hard to distinguish between the two. So MRI will tell you that. And then CT again, CT is very important for scaphoids. So for all the non-union scaphoids, you will be able to see your humpback deformities. Very important because it gives you an idea how much to correct, how much graft you need. And CT will tell you prognosis in the sense, if your fracture is proximal, the more proximal it is, the worse the prognosis. So you can tell your patient there's a lot of surety. Fracture type. So not all fractures are very clear. They don't have a clear pattern. For example, you may have a fracture which you think is more towards waist, but when you see your 3D CT scans and your coronal and sagittal and axial cuts of CT, fracture line may be exiting very proximally. So those are the ones which are more proximal pole than waist. So CT and healing, of course, again, at 6 weeks, if there's a waist scaphoid fracture, someone young. Now remember, scaphoid 2/3 is covered with cartilage. So even at 3 months on X-ray, I cannot tell my patients that, okay, I cannot assure my patient that their scaphoid is healed. So if patient is clinically very tender at around 6 weeks when plaster comes off, that's the time I would get a CT scan, because I don't want to carry on with scaphoid cast more than 6 weeks in a waist. So CT plays a big role in scaphoid injuries. It's very important to appreciate that fact. Plaster immobilization, that's another question that can come up. Do you want to give your patients a Colles type cast or a scaphoid type cast? Now, or is it going to be a above elbow or a below elbow? So the answer is it's going to be below elbow, and it's going to be a Colles type cast. The reason being, so with Colles type cast, as you can see, patient can mobilize thumb. Now, even so with thumb movements, they've done studies and found out that when patient is moving thumb, i.e. patient is in a Colles cast, there is some movement at the scaphoid fracture site. It's not enough to stop healing. And that's why there is no need to immobilize thumb. Of course, for some reason, in a proximal pole, if you manage it non-operatively, remember all proximal poles should be treated surgically, but let's say patient doesn't want it or medical issues, then yes, you can give a sort of a scaphoid cast. Otherwise, there's no role of scaphoid cast. Indications, well, one more point to add, obviously, if you do a proximal pole fixation, a non-union fixation, or if it's a very proximal pole fracture, in those cases also I'll give a scaphoid cast, because I don't want any movements in my proximal pole non-unions, no matter how small. Then, yeah, so let's come to the indications. So this is one question you'll be asked in the exam. So if you remember Herbert classification, so carpal fracture dislocations, this is your transcaphoid parilunates, Herbert B4, all of them needs to be done. Displaced fractures. Displaced means your Herbert B2 waist, but if it's displaced. Now, question, so you can be asked, how do you define displacement in scaphoid? Displacement is 1 millimeter. Now it's hard to measure a millimeter on an X-ray. So the answer, logical thing to say is millimeter, i.e. if I can see any displacement on an X-ray in scaphoid, to me that is a displaced fracture. Other thing is your intrascaphoid angle is normally around 30. But if you get a humpback type deformity in acute fracture, i.e. the distal pole flexes, that's a reason to operate and correct the orientation of scaphoid. Fractures through cysts. So we know in wrist bones, where there's any wrist bone, they can have cysts, like renal cyst or liver cyst. If there's a fracture through a cyst, you want to operate on them. Proximal pole. All proximal poles needs to be operated upon. There's a 30% non-union chance, 1 in 3 patients. If you treat it with a plaster, it won't heal up. 30% is very high, so all of them need surgery. And then delayed presentation. Any patient who comes to you after a month, waist, proximal pole, any fracture, except if it's a very distal pole or a tubercle or an incomplete fracture. So those are the ones which have a very high rate of non-union. So those are the ones you need to operate, even if it's a undisplaced waist. So delayed presentation. So this slide is important because these are your indications to fix them, and you need to know how to define displacement in a scaphoid. Then another question that can come up in the exam is, what about undisplaced waist? So we know displaced waist will operate, but an undisplaced waist. So would you want to fix it or a plaster? Now, by and large, 90% undisplaced waist in my practice, I would give a plaster slab for 6 weeks and then get their wrist going. But once in a while, I'll see a young man who, let's say, works in central London. Sort of he can't afford to have plaster for 6 weeks. For him, time is money. He's a financial advisor, for example. So those are the ones you need to sit and have a discussion, pros and cons of a percutaneous fixation versus plaster. So percutaneous fixation, Again, remember at 2 years, there's no difference whether you give a plaster or a screw fixation percutaneously. But important is these two lines here. With a percutaneous fixation, healing is a bit quicker, around 2 months versus 3 months for a plaster. So they can return to work quicker, around 2 months versus around 4 months without a plaster. Now for someone for whom time is money, 6 weeks, 8 weeks matter a lot. Other advantage with percutaneous is you don't need a plaster. So obviously they can start early mobilization. You don't need to call them weekly for serial x-rays for first 2 or 3 weeks. So obviously they don't need to take time off from the work. Healing is quicker, return to work is quicker. Even though at 2 years, both patients will do equally well. But it comes with its own baggage. As with any surgery, things can go wrong. Obviously general anesthesia, because you are doing it percutaneously, like with a little stab, infections can happen, screws can be prominent, screw can back out, so all those problems. So you need to sit and have a discussion with patient about pros and cons, and then he can decide for himself. Percutaneous, again, in my practice, as I said, I'll do maybe 1 or 2 case, 1 case, maybe 2 case at the most, percutaneous. And the way to do it is, obviously this is a waist fracture. Again, for exam purpose, you have to say ATLS, consenting, positioning on table, your checklist, your cleaning and draping. And once you've done all that, first what you do is with your II, you get your wire right in all the 4 views which we discussed about. And once you're happy, then you create a little stab. This is a bit too big incision, but yeah, something like that, like, I don't know, 6 to 10 millimeters. And then your screw goes in basically, and that's it. Other question here, that's why I put these screws on this slide. Yeah, another thing to remember is whatever you measure, take 4 less. That's important because you will be causing some compression here. Second important point, these screws, you will be asked, or you may be given a screw and asked, what is this screw, or what screw do you use in a scaphoid? So the answer is it's a variable pitch screw. So whether you take something like this, Accumate screw, which has a continuous variable pitch, and you can see the lead pitch is more than the trial pitch. So when this lead pitch crosses the fracture site, it will cause compression. Or you can take something like a AO headless compression screw. Lead pitch is more than a trial pitch. What screw you choose doesn't matter. What matters is it's a variable pitch screw. And how does a variable pitch works? That's important. How does it cause compression? So we've spoken about plasters, we've spoken about percutaneous fixation. Then let's talk about open approaches. So for a waist fracture, we do a volar approach. And for a proximal pole fracture, we'll do a dorsal approach. Like, this is very important. So in the exam, depending on where the fracture is, your approach changes. So please remember that. Volar approach. I'm sorry, I didn't get a sort of chance to put my own slides, which I should do for the next presentation, but we'll go through these pictures. So we've all done distal radius through volar approach. We all know the FCR approach. Here, incision, so look at this, basically. This is all you need to fix a straightforward scaphoid waist. If you need a graft, you need to just extend this incision 2 more centimeters proximally. So distal radius incision is somewhere there, and you follow it down to scaphoid tubercle and you curve it. And then you can see that's your median nerve, flexor carpi radialis. Again, like distal radius, you never go through the sheath, go with your incision next to it. FCR goes radially, ulnarward, sorry, and it'll protect your median nerve. And then if you see this picture, so you've done your skin and fat, FCR is protecting median nerve, you're aware of your radial vessel. Then if you see this diagram here, this is your radio scaphocapitate ligament. That's your main ligament, sling ligament. So when you are coming with your incision in this plane, you will have to cut this ligament. But this ligament is a condensation of capsule. They're one. You can't differentiate the two. So what you do is, once at this stage, with your knife, you go straight down onto the bone. So this ligament and capsule, you make two flaps. A flap goes there and a flap comes here. And then scaphoid will look at you. You can put your wire. You can see those 4 X-rays, which I will show you many more as we see some examples. And once you've centered your wire in all your 4 views, then you can measure your screw and you can put your screw. So let's see one example for a Volar approach. So we know that's a waist scaphoid. So you'll be shown this X-ray. They'll start with maybe one view, and you have to say it's a PA view wrist. Then you can say, I can see a scaphoid fracture. It's a hyperextension injury. And every time you comment on scaphoid, take a moment to make sure it's not a transscaphoid perilunate injury. Always rule that out. We're not talking about perilunates today, but in the exam, you need to rule that out. Yes. So once you've established it's an isolated waist injury and it's not a non-union waist, then you can ask for other views. Always ask for all the views. And see, for example, this is a 45-degree supination view. So here you can see proximal pole very nicely, whereas distal pole is all merged in other bones. Similarly, this is a pronation for view, 45 degrees. You can see your distal pole, but you can't see your proximal pole. Lateral view, as I told you, you don't see a lot other than relationship of your lunate to scaphoid and your scapholunate angles. So we know it's an acute injury. We know it's a waist fracture. We know there are no perilunate injuries. We know there are no signs of non-union. So question is management. Now here I can see fracture line very clearly. Again, one can argue you can manage this non-operatively, but equally you have a discussion with your patient. And sort of, I don't like if I see fracture lines so clearly, so I'll be towards operative. So again, X-ray 6 months post-op, 8 months post-op, you can see the healing. But important thing here was for me to show you these pronation, supination views, which I'll keep harping as I show you more and more examples, because these two views are very important. For example, this is a supination view. You can see the wrist is in supination. It'll not, it's showing the other one, but this is supination if you see from my angle. So supination, pronation, and in a supination view, see proximal pole there, and screw is almost in the center. So all I'm looking at in this view is my screw tip. Is it penetrating? Is it going into the joint? And is it centered? Then this is a pronation view. All I'm looking at is my distal pole. Is the screw penetrating and where is it? Normally you can't center it in pronation view because entry point is sort of very radial. So, okay, then let's come to the dorsal approach. So I will look for proximal pole fractures. Now, like distal radius, which we were talking last Sunday, workhorse for a hand surgeon is a dorsal approach. Volar approach, you do very few things. One, you deal with a waist scaphoid. Two, a straightforward volar plating. Most of the work to the wrist is through dorsal approach. So whether you want to fix your proximal pole scaphoid, whether you want to do your total wrist fusions, partial fusions, proximal row carpectomies, wrist replacements, your Vaughan Jacksons for rheumatoid, almost your dorsal platings, your spanning wrist platings, almost everything is through dorsal approach. So this is one approach you need to familiarize yourself with. Now, dorsal approach again, after all your clean drape, consent, everything done, then so if you see that's listers and you can palpate in your own wrist, exactly a centimeter in front to listers is your radiocarpal joint. That's where you aspirate for your wrist, septic wrist. And that's where your proximal pole to scaphoid is. Exactly a centimeter in front of your listers. So your incision, incision is as shown. You can extend it a bit proximally. First step, like we were talking again last time, is to save your cutaneous nerve. So you go right down to the retinaculum, skin and fat, you make two big nice flaps that protects your cutaneous nerve. Retinaculum here, because you're dealing with scaphoid, you just need to incise distal half of retinaculum through the third compartment. And then for capsule, you don't need to make a big burger flap. You just need a small, like a mayo flap. So incise capsule here, put a vest, and that's enough to show you proximal pole of scaphoid. That's all you need to see. Remember, proximal pole of scaphoid do not have displacements. So you don't want to disrupt a lot of blood supply. I will, in fact, for example, if my fracture is here, I won't even expose this much. I leave the capsule on distally as much as I can to allow that distal supply. So I'm not disturbing that distal supply from the dorsal carpal branch. And as I said, you will never ever see a big gap. In fact, more often than not, when you go in there, you hardly see a gap. So all you need to do is, in an acute situation, you do disturb nothing. That's your scapholunate ligament, very close to the ligament, somewhere there where this dot is. You just put a screw. See how little exposure we have done here. Yeah, that's your EPL. You radialize your EPL. You leave all the capsule attachment. I can't see my fracture here because you can hardly see your fracture. And you entry point, you do your 4 views and you put your screw. If it's a non-union situation, I'll show you what I do in the coming slides. So example of a proximal pole, again 29. These are injuries of young men, mostly men. I'll hardly ever see a scaphoid fracture in a woman. So 29-year-old male, again hyperextension injury. So in an exams, you will be asked to diagnose what investigations and how will you manage. So again, you describe your x-rays, PA view, wrist. You can see a proximal pole fracture, no perilunate injuries. But see, important thing is here is it's a small fragment. Proximal poles are quite small. And if you see another view, it looks even more funny. So I would, in a proximal pole, unless it's a big proximal pole, I'll ask for a CT scan. So in a CT scan, you can see, and other thing to appreciate here is that's the fracture line, yes, but there's never a humpback in a proximal pole. Remember that. Proximal poles are very stable. You don't get bone loss. You don't get humpbacks. You don't get disc deformity in proximal poles. So, and again, in a coronal cut, you can see. And other thing to appreciate is this fracture line. Now, remember, imagine a situation where the fracture line is exiting very vertically. This is a transverse line, but it can be very vertical. And that's why your CTs are your best friends. Because once you know your fracture lines, then you can accordingly place a screw. Because there's not a lot of bone here for your screw. You need to put a 3 millimeter screw. This bone is hardly 6, 7, 8 millimeters, if that, 6 to 7 millimeters. So sometimes you may have to take even a 2.4 screw, hence the role of CT scan. And yeah, so, and then, yes, so it's going to be a dorsal approach in proximal pole, and it's going to be an anti-grade screw, because obviously if you're going dorsal approach, you need to put your screw from there, anti-grade screw. Other important thing in proximal pole, as I said, you cannot determine healing at 3 months because 2/3 scaphoid is covered with cartilage. So your final X-ray in a proximal pole has to be at 1 year. Even at 6 months, if you do an X-ray, it all looks good, you discharge them. They go back to doing something very heavy, this can all fall apart. Proximal pole, final X-ray, 1 year. Length of plaster treatment. Again, no right or wrong. How long is a piece of string? As I was just telling you, waist I will give 6 weeks. Waist, if somebody's a heavy smoker, I can even give it for 8 weeks. Proximal pole, normally around 3 months. That's the sort of ballpark figure. Yeah. Then non-union. So we've seen waist fracture, volar approach, proximal pole fracture, dorsal approach. Now, what are the signs of sort of non-union? When will you be worried? So important is in a waist fracture, when you're following them up, if the fracture line starts becoming more and more visible, and again, because of hydrostatic pressure, if you start noticing early cysts, you know this patient is not going to do well. You know this patient is going to go into delayed union or non-union. So again, you can be shown an X-ray like this. So remember, if you see big gaps in scaphoid, more or less they are non-unions. So you need to describe all the signs of non-union. You shouldn't be seeing so much gap. Cysts we've spoken about because all the fluid will seep in, especially if they're clenching their fist very tightly. And then, of course, if you're thinking of a proximal pole, you will think of blood supply, you'll think of AVN, fragmentation. You can, and for any non-union work in scaphoid, you'll get your CT scan. You can even get an MRI to look for AVN. Then let's go into scaphoid non-unions in a bit more detail. So what are the causes? Natural history. So if I leave a scaphoid non-union, or patient doesn't come to me, what will happen in 5 years, 10 years, 15 years? How do they progress? And then how do we treat them? Causes, two main things. Of course, smoking matters, patient compliance matters, delayed presentation matters. All those things are very important. Blood supply. So that's another question they can ask you. Blood supply to scaphoid and intra-articular pressure, which we have discussed about. So blood supply, you need to know dorsal vessels. So your radial artery, once it goes dorsal, it will give a dorsal carpal branch. That dorsal carpal branch is the sole supply to proximal pole, and almost 70–80% of the total scaphoid is by the dorsal carpal branch. So you can see this is the dorsum, that's the dorsal carpal branch, and it's giving this blood supply to scaphoid. And what you see here is all the supply is retrograde, coming sort of from the waist area. There's a ridge at the back from where it comes. And similarly, if you see here, all the supply right from there is all retrograde. So if there was a fracture here or at this area, this blood supply goes. Hence 30% non-union in non-operative. And then of course, very distal part is supplied by the palmar carpal branch, which then goes on to make a palmar arch. So blood supply is important. Of course, some blood supply will come through scapholunate ligament also. The proximal poles equals dorsal carpal branch supply. So that's important, along with the other factors which can cause non-union. Now, if a non-union has happened, and we see it quite commonly, I'm sure in India you will see much more than I see here, that people get a scaphoid fracture, but they come to you very late. So what's the natural history for a waist and a natural history for a proximal pole? So for a waist, there are two types. Waist can be a stable waist or an unstable waist. Stable means the force is stable in long axis. So the weight is able to take axial loads. So if it is able to take loads, it will not have those classical humpbacks. It's not going to collapse. It may form some cysts because of hydrostatic pressure and some fibrous non-union. So these are the ones which can even come after 10 years, 15 years, but you will not see classical SNAC. So if you ever wondered why one X-ray, one waist has SNAC and the other doesn't, this is the reason, because they were stable waist. Unstable waist, obviously they don't take the load. They're unstable in long axis. So they start collapsing. I'll show you in the next slide what it means, which is known as a humpback. And obviously cysts will form, we know that. Erosion, I'll show you in the next slide. And then of course, they are the ones which goes into SNAC 1, 2, 3, 4. So mid-carpal collapse happens. Other thing to remember, scaphoid is a different kettle of fish in very young people. So sometimes I'll see 13, 14, 15 years old with scaphoid. These are the ones you have to watch very carefully, in the sense, if left untreated, not given a plaster, they can collapse and they can go into humpbacks. And then of course, if a humpback happens, then dorsal spurs, osteophytes and spikes will form, which will give you impingement on extension. Again, I'll show you in the next slide what it means. So see here, unstable waist, humpback equals humpback. So that's a waist fracture, acute injury, sit on it for a little while, see how distal pole is flexing. Intrascaphoid angle is almost 75–80 degrees. It should be around 30. And then you sit on it, or patient doesn't come to you for a little while more, it keeps collapsing. So if you see in these diagrams, these are representatives of the X-rays I've shown you. This is how fracture starts. And again, watch the fracture lines. They're not always horizontal. They can be vertical lines. Hence the importance of CT. And see how it's collapsing. So what happens is scaphoid starts eroding into the waist of the distal pole. The proximal pole erodes. You sit on it long enough, proximal pole will erode more. And that's why these dorsal sort of spurs, osteophytes will form. And obviously when a patient will extend the wrist, this dorsal osteophyte will impinge on the dorsal rim. So how do we correct humpback? So that's a normal scaphoid. That's a humpback, which I just showed you in the previous slide. So you can see this is a normal intrascaphoid angle. This angle has become, has increased 60, 70 degrees, 80 degrees. So what happens is, obviously, because all the collapse is from the front, you need a Volar approach. You need to reorient it. And this is how you jack it out. Once you've jacked out, at this stage, you need to hold it with a wire. Again, do your 4 views, center your wire in the scaphoid. Once you've done that, it's only at that stage that you put your graft. So this is very important. You can't put a graft and then start putting KYs because graft will all disperse. Correct the orientation, put your wire in the X-ray. Once you're happy, put a graft, measure the screw and put a screw. This is the sequence of doing it. And of course, we're going to see them when I show you some of my cases. And then, so we've seen unstable waist. Now this is a stable waist. Stable in the sense axial load is able to take the axial load, so it doesn't collapse. If it doesn't collapse, it doesn't progress into SNAC. So this is an acute fracture, week 1, week 2. But you can see after many years, it hasn't collapsed. You can see there's no arthritis here or in the mid-carpal joint. But you can see there's a lot of sclerosis, i.e. is many years old. So these are the ones you can sit on it for 5 years, 10 years, 15 years. They will not progress into SNAC. So this is a case of non-union of a waist scaphoid. Yeah, again, it's not a very classical in the sense but still, there are still some finding. So again, if you're shown this X-ray, you will say it's a PA wrist because ulnar styloid is most ulnar. You can see there's a clear displacement and look at that small cyst. And you can see those corresponding cysts in CT. So in any non-union work, you always ask for a CT scan. Why I have put the same diagram from the last slide here. If you sit on it, this distal pole will flex, proximal pole will erode into the bone here. It will become a classical humpback like this. And again, on II, this is a different patient, but just for explanation, I put it here. As I was saying, you go from the Volar approach, you correct the humpback, you see all your 4 views, and whatever gap you have now, you take a distal radius graft. This width is roughly a centimeter. So you take a centimeter there, and this width is roughly 5 millimeters. So 5 millimeters, 1 centimeter is your corticocancellous graft. You put a lot of cancellous chips, very thin cortical piece there, and then you put a screw. So order is Volar approach, correct humpback first, hold it with KY on all the 4 views, and then you pack it up with your graft, finally a screw. So let's come to proximal pole now, natural history. Again, proximal poles, they behave very well. They are like stable waist. They don't collapse. They don't get humpbacks. They don't get disc deformities. But proximal pole has a problem because of the blood supply to proximal pole. They can get AVN, and finally they can start fragmenting. So you can always do an MRI to see your AVN and fragmentation. Practically, we do CTs and it kind of gives us all the information. But for exam reason, you will say, I'll do a CT scan to look at my fracture lines. Then I'll do an MRI to look at AVN and fragmentation. So another example of proximal pole. So 29, I think we have shown a bit there, but 29, same guy, and you can see. so basically CT is telling you the orientation of the fracture line. So if you think very carefully, you'll have to be very careful how you put your screw here, because this is a small fragment. And again, 1 year post-op. So that's a repetition actually, but yeah. Now, so again, secondary effects, i.e. natural history. So we know humpback doesn't happen because it's stable in long axis. Disc deformity doesn't happen. So if it's not collapsing, SNAC won't happen. But yes, it can have some dorsal spur formation, some dorsal osteophytes, basically. And as I was telling you, this line is important. Articular surface wear is unusual. So what it means is, unlike a waist fracture, for a proximal pole, when you go through a dorsal approach, sometimes you can hardly even see the fracture line. Articular surface wear doesn't happen. Hence, if on a CT I knew it was a non-union, then you have to create that fracture line almost and freshen the edges. Take a wire, drill both the surfaces, let nice mesenchymal stem cells come out, and then fix with a screw. Vascularized graft, I personally have no experience. I've never put one, not even assisted one. But yes, for exam purpose, you do an MRI. If there's an AVN, you can talk about vascularized graft. You can take this 1-2 intercompartmental artery from the dorsum. And similarly, you can take one from the volar also. But I don't think, for all practical purposes, vascular grafts are almost non-existent. So if you just know the name, they will not ask you to go any further. So far, before we go into SLAC and SNAC, so far we've discussed volar approach, waist fractures, we've discussed signs of non-union, we've discussed how to fix them, the tips and tricks, we've discussed what is humpback, how to correct it, put a wire, then a graft. Talking of graft for exams, distal radius grafts are as good as iliac crest grafts. So in my practice, if I do 20-25 non-unions to waist, maybe one case I'll have iliac crest graft. Because if there's a really huge gap, i.e. a huge humpback, huge erosion, huge bone loss, only then will I take a iliac crest graft. Otherwise, distal radius graft serves the same purpose and is more often than not sufficient. And then we have discussed the natural history of waist. So unstable waist will give you SNAC. Stable waist stays like that. Proximal pole behaves like a stable waist. You don't get a SNAC. Proximal poles, you don't see huge gaps. So you do not fiddle with the fracture so much. You do your dorsal approach, but you retain your capsular attachments as much as you can. Now coming to SLAC and SNAC. Sort of this representation is important here. And again, I'll repeat it a few times as we go along, because this is the key to understanding SLAC and SNAC. So in a rest, the way biomechanics works is forces will come from styloid and go in this fashion towards ulnar styloid. Remember that. So that is why the arthritis starts from radial end, if you like, and go towards ulnar end. Hence these Mayfield 4 stages. Arthritis will start here, then goes to capitolunate, lunotricutal, finally radiolunate. Yeah, so forces comes from the radial side, goes to the ulnar side. And this is the reason you will get all those parilunate injuries. For example, if you see here, you will get transradial styloid, transcaphoid, capitate, even hamate, even tricutum, and it can exit through ulnar styloid. Or you can have styloid is fine, transcaphoid, instead of going through the bone, it can go through capitolunate and come out through lunotricutal. So you can, I'll go to the next slide and come back here just to harp on this point. So you can have all sorts of patterns, but once you appreciate that forces start radially and come ulnarwards, you can make your own fracture patterns, all sorts of combinations. For example, forces can just go through here and take off scapholunate ligament, pure scapholunate ligament injury. And then if you carry it forward, forces can then keep going and come out through lunotricutal. So you can have both the ligaments which can go, your lesser arc injury. Or, for example, here, instead of going, forces can come through your radial styloid and then go through capitolunate, come out through lunotricutal. lunotricutal. So it becomes a transradial styloid lunotricutal perilunate injury. Or forces could have come through styloid. Instead of going through capitolunate joint, they could have gone through capitate, hamate, tricutrum, or they could have gone through capitate, come down through lunotricutal. So once you understand forces are coming from radius to ulna, none of the fracture patterns will bother you. And for all of them, I've told you the approach is dorsal. Whichever bone is broken, you put a screw, you can fix it. So scaphoid perilunate injury should not be difficult to answer in the exam. Coming back to the same slide, because we are not discussing perilunate today, we're talking about scapholunate and SLAC injuries. Now remember one more point here. Scaphoid, like your hip joint, scaphoid is sitting in a saucer in the radial styloid here. So it's like a golf ball sitting on a tee, or think of a hip joint. So what will happen when your scapholunate ligament goes? Scaphoid will flex. So this congruency will change. Saucer is there, but the scaphoid has flexed. Once it becomes incongruent, like a knee or a hip, next thing will be progression of arthritis. Arthritis, as we've just said, it'll start from here, then it'll go into this area, into capitolunate, and finally come to radiolunate. So whether it's a SLAC, let's say SNAC now. Let's say we had a fracture, waist non-union or a proximal non-union. So this bit of scaphoid starts behaving like a lunate. So only the distal half of scaphoid will flex now, i.e. become incongruent. So arthritis will happen in the distal half of scaphoid, then it'll go to scaphocapitate, because once this distal half is flexed, it's incongruous here, and it'll be incongruous here also in the scaphocapitate joint. Then arthritis will come to capitolunate and finally to radiolunate. Now, radiolunate arthritis is very rare to have. The reason is radiolunate joint here is like a hip joint. It's a very congruous joint. So that's why knee arthritis is more common than hip, because hip is more congruous than knee. And radiolunate behaves like a hip. So arthritis is very uncommon. So this slide is very important to understand force transmissions, SLAC and SNAC. A lot of times I've seen sort of exam going candidates, they get very confused with SLAC and SNAC staging. They are actually the same, because force transmission is the same. Only difference is in a SNAC, this part of scaphoid starts behaving like a lunate. There's absolutely no other difference. So for example, I've just put a slide here, just sort of to what we were discussing at the moment, just at that time. This is a transradial styloid scapholunate injury. And if you take it one step further, it could have been a lunotricutal also, or a capitate fracture and a tricutal fracture, or a ulnar styloid fracture. So it could have gone in any shape. So one thing to learn here is any radial styloid fractures, because they're quite common bread and butter fractures in clinic. You must look for any associated ligament or carpal bone fractures, i.e. a perilunate injury. And then, of course, this has the classical signs, the Terry-Thomas sign, i.e. the increased gap. You can see scaphoid is flexed, which you can appreciate very well here. Scaphoid is flexed here. And scapholunate angle is more than 90 actually. And as I was telling you on the lateral view, see where the lunate is and see where the scaphoid proximal pole is. Normally scaphoid should be sitting inside lunate. That relationship is gone. So this is what you appreciate in a lateral view. So let's see some examples of scapholunate injury to start with, then we'll go to SLAC. So 54-year-old female, she came in with acute scapholunate ligament injury. Now, unlike the previous slide, where it's a Barndo scapholunate, here if you see, it's not very classical. All I could see was a little triangular gap. And so, but she had marked swelling and pain over scapholunate ligament. As I told you, scapholunate is a centimeter distal to Lister's tubercle. You can palpate it. So I said, okay, fine. One option was to get an MRI scan. I did get an MRI scan. It suggested an injury, but it was a bit inconclusive. They were not sure whether it was a complete injury or a partial. So I took her for a scope. These are the slides from the scope. And if you see, this is lunate, this is scaphoid. And you can see there's a huge gap. You don't need to know this for exam, but this is a stage 3, which I'll show you in the next slide what I mean. But bottom line is a injury, scapholunate ligament injury. This is a injury enough for me to do an open scapholunate ligament repair. So what did we do? Again, dorsal approach. And then important is, we know scaphoid flexes, lunate extends, disc deformity. So I need to correct their orientation first. That's the first step. So you put these 2 wires, joystick wires, wire in scaphoid, wire in lunate. You correct scaphoid flexion, lunate extension. Once you've got your disc corrected, you need to now control that. So radial styloid, good centimeter incision to protect your superficial radial nerves. Wire comes from scaphoid to lunate, wire comes from scaphoid to capitate. So that will now control your orientation. Once I'm happy with that, these 2 stick wires come out. Now, if I leave it at that, if I don't put these 2 anchors, my ligament will heal up very nicely, because these 2 wires can hold my scaphoid and lunate in the right orientation. So why put these 2 anchors? The reason is capsule still has to, because capsule has come off the dorsum of the radius. So these 2 anchors with the sutures, you take bites in capsule and you tie your knots on top, on dorsum of capsule. So it slaps the capsule onto my carpus and allows those septa to form again, capsulodesis. So this is the technique I use, washing line technique. Of course, there are many other techniques described. And then same in lady, ear post-op. Why ear post-op? Because scapholunate ligament can stretch out. So after a year, I know my my gap is okay. And most important, look at the lunate. Lunate is pointing up, it's not extended. Look at the scaphoid. My scapholunate angle is absolutely right, 45, 50 degrees. So that's why you see them at 1 year and you discharge them. So scapholunate, I was showing you from mid-carpal joint, the scapholunate ligament. You don't need to know this Geisler classification. But important thing is, like ankle sprains, it can be mild, moderate, severe, isn't it? Mild sprain is swelling, moderate is a bit of bruising, and severe is marked bruising and swelling. Same with scapholunate ligament. So if you see stage 1 is just a bit of, stage 1, you just see a few sort of fibers which are toned, 2 bit more tone, 3 is what I showed you last picture, and look at the stage 4. So compare stage 1 to stage 4. That's your scaphoid, that's your lunate, mid-carpal joint, and I can put my whole scope into radiocarpal joint. It's such a big gap. Complete rupture, just a few fibers gone. So all I want you to appreciate is scapholunate, it can, like your ankle, like any ligament in the body, can have a partial sprain or a complete sprain. If it's type 1 and type 2, you don't need to fix them, repair them. Type 3 and 4, you need to repair them, otherwise they will progress into SLAC. I've deliberately put this slide again to revise. So SLAC is ligament goes, scaphoid flexes, this orientation will change, this orientation will change. The way forces go, arthritis starts at this end, goes to scaphocapitate, capitolunate, radiolunate, which is your SLAC 4, SLAC 1, 2, 3, 4, and your SNAC 1, 2, 3, 4. So let's see some examples of SLAC. Now, other thing to appreciate in SLAC wrist is, at least in my practice, I'm not sure how it is in India, but in UK, what I've seen is patients with SLAC, they come at a very late stage, SLAC and SNAC. They don't come in SLAC or SNAC 1 and 2. It's normally SLAC 3. It has sort of arthritis has quite advanced. If I do 10 SLAC wrists, 9 will be SLAC 3. So, okay, so 69 male SLAC 3 wrist. You can see here scapholunate ligament disruption, as is often the case, because it's upper limb, they don't feel the pain or they can cope with pain. They leave it for 5 years, 10 years, and then they get arthritis, pain, loss of movements, they can't do their job or their hobbies, and they come back, they come and see me. So you can clearly see here, SLAC 1, SLAC 2, again, ligament gone, orientation has changed, arthritis starts here, SLAC 1, SLAC 2, then it'll go to scaphocapitate and capitolunate, and finally to radiolunate. Now, you can see a bit of sclerosis. So we know there was a SLAC 3, but how do I know how's my radiolunate joint? So I will always put a wrist arthroscopy. I'll do a wrist scope first, and I'll stage my SLAC. So this was SLAC 3, i.e. radiolunate joint was okay. So if it is and you can see on wrist scope, so see radioscaphoid joint, you can see complete loss of surface like your knee or a hip, and you can see that's radius, bare bone, like your knee arthroscopy, scaphoid bare bone. And then I went to, this was radiocarpal scope or portal. Then I went into mid-carpal joint, and you can see capitate. There's a grade 4 loss of cartilage in this localized, and here in the lunate. Lunate, capitate, capitate. So I know it was a SLAC 3. SLAC 3 means I can do a scaphoid excision, 4-corner fusion. You can't do a PRC because your capitate proximal pole is gone, arthritic. If you do PRC, this will sit on the radius and patient will have pain. Yeah. So for a SLAC and a SNAC wrist, arthroscopy is the only thing. MRI, unlike a knee MRI scan where you can comment on cartilage on MRI, you cannot comment on cartilage in an MRI wrist because wrist cartilage is thinner, and we don't have enough thin MRI slices to comment with surety whether it's gone or not gone. So always in exam, if you're shown a SLAC or a SNAC wrist, say I'm going to scope it, I'm going to stage it. Once I know whether it's a SLAC 3 or a SLAC 4, accordingly I'll treat it. So I did a 4-corner fusion. You can see trabeculae, so it's all healed up. It's an X-ray 1 year post-op. So scaphoidectomy, 4-corner fusion. Other thing is, if the carpus is impinging on the styloid, you also do a styloidectomy, which you can see on your II images at the time of surgery. Next X-ray. So I'm going to show you lots of SLAC 3 because this is what you're going to be shown in the exam. Or you can get a clinical case because a lot of patients, as you would know, can live with wrist arthritis. So it's a chronic sort of a wrist arthritis. They can keep coming year after year to the exams. And SLAC, scapholunate ligament, is the most common injured ligament. SLAC wrist is much commonly seen than a SNAC wrist. So SLAC is one thing if there's any dorsal-radial wrist pain, chances are it's going to be a SLAC wrist or a kind box, one of the two. So yeah, 65-year-old female, SLAC 3 again on wrist scope. I have shown you the wrist scopy pictures before. So we know it's a SLAC 3 wrist. And there was another problem here. If you see, there's no trapezium. She had a trapeziectomy 8 to 10 years back. So the thumb has completely sagged. It's hitting now the trapezoid and the scaphoid. So similar thing, dorsal approach, scaphoidectomy, 4-corner fusion using my spider plates. This time I've taken a graft from radius, as you can see, put a lot of graft there. And for the metacarpal sag, I've taken the ECRL tendon and weaved it around it and then attached it here. So her thumb is suspended on the ECRL tendon. And then lateral view, important thing with spider plates is this dorsal rim, if it's not sunken into the carpus, it can impinge on the distal radius when the patient extends the wrist. So that is what you need to check when you're doing it on your II images. Another SLAC 3 wrist. So same problem, you can see here, the scapholunate ligament gone. You can clearly see radioscaphoid arthritis, some sclerosis in the mid-carpal joint. So SLAC 1, SLAC 2, scaphocapitate and capitolunate becomes SLAC 3. Put a scope, see the radiolunate joint if it's pristine, so it is a SLAC 3 then. Similar operation, scaphoidectomy, 4-corner fusion, and radial styloidectomy. Now, the reason I put this slide in lots of II images is, for example, here, you can see clearly this carpus is impinging on the styloid. So this patient needs styloidectomy. Always check on II. This X-ray kind of shows you very nicely 2 screws in lunate and 2 in capitate. So most important is your lunate has to fuse to capitate out of the 4 bones. Then this image shows palmar flexion. I haven't got an image to show extension, which is more important, but I'll show you in the next slide on the same patient. But what I'm showing here is, again, this tip of plate is nicely sunk. It's not going to hit my dorsal rim of radius. And if I show you so always do II images to check for the motion. Now, in your wrist work, important is, so when we grip, grip equals extension. You can't grip in flexion. It is always in extension. So if you're doing a four-corner fusion, you know you're going to lose half the movements, but you want to lose more movements on the palmar flexural side, and you want to give them more dorsiflexion, more extension, because that's where the grip comes. Palmar flexion, you only need 10-15 degrees for hygiene purpose. Extension, you need at least 20 degrees, if not 30, to grip things. So always do these images to check for impingements and to check for extensions. And then if I show you, it's the same patient after 1 year. This slide shows you all the bridging trabeculae is nicely healed and all the nice screws. But now you can see the extension. So he can extend very nicely to 30-40 degrees. And this is not him, like, this is him going for a casual x-ray, not trying to extend and show me how much extension he gets. So you have to aim for at least 20 degrees. Same with total wrist fusions. You're going to fuse them in a bit of extension around 15 degrees, 15 degrees, 20 degrees. If you fuse them straight, they won't have a good function and they're not happy, and you have to go and revise them. So few tips with four-corner fusions. Those of you who want to become hand surgeons, check all the movements. Make sure your screws are in lunate and capitate. Make sure they get more extension than flexion. Make sure this is not impinging on the dorsal rim. Again, I have just put this slide not sort of just to show you dorsal impingement. So compared to the last slide, look at how this plate is prominent there. Can you see that? And this, obviously, when patient extends, this will hit the dorsal rim. He will never be happy. So you can see on CTs, this is prominent there, it's prominent there. And again, if you see on CT, sort of that lipping osteophyte and the prominence, lipping osteophyte, prominence. So this patient needs plate removal. But because we had done CT scan, I thought I'll put these slides also. See how nicely the screws are spread. Radius, lunate, I've got 2 screws in lunate, 3 in capitate. That's where most of your screws should go. And it should spread all around in all your 4 bones. And obviously, before you take your plate out, you do a CT to see healing also. You can see it's all one lump of bone now. So we took the plate out and his pain went away. And obviously, at the time of surgery, the dorsal rim of radiate had huge lipping osteophytes. So no wonder he was suffering. So we've spoken about SLAC now. I've shown you a lot of SLAC 3 x-rays. Obviously, if you get a SLAC 1 or a SLAC 2, for example, here, if on a wrist scope, your mid-carpal joint was okay and your radiolunate joint was okay. So if it was a SLAC 2, then I can do a PRC because this pole is pristine, this cartilage is pristine, or I can excise scaphoid and do a four-corner fusion. So if it's just a SLAC 1, then if I just do styloidectomy, then this bare bone is not rubbing on this bone now. So patient will be fine. So SLAC 1, 2 is very easy to manage. 3 and 4, again, if you think of that biomechanics picture I've shown you, it's very easy to comprehend and decide for a surgery. Then scaphoid non-unions, SNAC, reconstruction versus salvage procedures. Again, as I said, in my practice, I only do CTs, but for exam purpose, you're going to mention both CT and MRI. CT scan, as I was telling you, it will tell you fracture lines, it will tell you displacements, erosions, humpbacks in waist non-unions. It will also tell you in proximal poles about fragmentation, about AVN, and then, yeah, if you want to look for your AVN, you can do an MRI, at least for exams, mention that. So we'll talk about reconstruction in a minute, but let's see salvage procedures. So salvage is, let's start with simple ones: radial styloidectomies, PRCs, four-corner fusions. If it's a SLAC or a SNAC 4, total wrist fusions. And sometimes in early stages, you can debride arthroscopically. And in elderly people who are very unfit for a surgery, you can manage them with steroids and with wrist denervations. It's a very handy procedure, wrist denervation. So in an elderly person with medical issues, this is what we often offer in our clinical practice here. So do remember this procedure. for a wrist arthritis. So again, SNAC, so you can see sort of, I think it's a proximal pole, but again, I'll get a CT to see it a bit better, but it is a proximal pole, I think. So you can see sclerosed ends. Sometimes you will see, I'm sure that's a cyst, but if I had a CT picture, you will find cysts. It's a proximal pole, so you will not see humpbacks. So you describe all those, and you can see a bit of arthritis there on the X-ray, so which you will confirm on a CT. So let's say if this was a SNAC 1, so we already know this piece of scaphoid will behave like a lunate. So you will get arthritis here because this bit of scaphoid has flexed incongruous with styloid, incongruous with capitate. So that will be SNAC 2. Then arthritis comes in this area, SNAC 3, and finally radiolunate SNAC 4. So for a SNAC 1, if you just do styloidectomy, this bare bone is not rubbing there. So patient will be pain-free. And for non-union, you will do a non-union surgery. If it's a waist, you go from Volar approach, you put a graft like we showed, distal radius, and you put a screw. If it's a proximal pole, you can go from dorsal approach, doesn't matter. So SNAC 1, you can do a reconstruction. But moment it goes to SNAC 2, you can't save your scaphoid. It's a salvage procedure. The reason being, again, so that's a SNAC 1. Now arthritis goes here, SNAC 2. And now if I, because this surface of scaphoid and capitate is arthritic, even if you fix this and do a styloidectomy, you still have an arthritic surface. Patient will be still painful. So it needs salvage. So what you can do is, if you do PRC, because your proximal pole of capitate is fine, it's the side of capitate which is arthritic, you will be fine. Easy, simple procedure in elderly patients. Or equally, you can excise scaphoid and do a four-corner fusion because your radiolunate joint is fine. So one or the other procedure depending on the age. SNAC 3. So SNAC 1, SNAC 2, 3 will be now capitolunate. So as I said, you stage your SNACs and SLACs with arthroscope. Once you've confirmed it's a SNAC 3, then you can, like your SLAC 3, excise scaphoid and do a four-corner fusion. Can you do a PRC? Answer is no, because this surface of capitate is arthritic. So capitate will come and articulate with your lunate fossa of radius. Arthritic surface, patient will have pain. So scaphoid excision, four-corner fusion. So in my practice, I would do a four-corner fusion using spider plates. These days, they're talking about 3 corners and 2 corners. I don't think you need to know for the exam at your stage. But as I was telling you before, your fusion to lunate and capitate is more important. So whether you put a spider plate or screws, you need to make sure these two surfaces fuse up. Then this is another case of mine, 50-year-old into a manual labor job. As I said, he had a scaphoid fracture. He never came to hospital. Now his wrist is arthritic. He can't work, so he's come to me. Now we got an MRI scan, and you can see here capitate lights up. So you know capitolunate is arthritic. But look at this. Because lunate is extending, every time patient will extend the wrist, these two surfaces will hit each other. And he's already got a cyst there. But as I said, MRI, you are never certain. You cannot comment on cartilages on MRI. So this was done by my sort of colleague when I was not around, I think. But in a way, it's good for academic purpose. So we know how MRI looks in arthritic wrist. So again, I did a wrist scope, and in a wrist scope, I found that radiolunate surface was gone, and MRI also corroborated. So that means it needs a total wrist fusion. So that's a total wrist fusion. This X-ray is 9 months. You can see the trabeculae from radius to lunate. And here you can see it's sort of all the bones are like a one lump of bone. Screw is slightly prominent. I'm not worried because clinically he couldn't feel it. And if it backs out further, which it shouldn't after 1 year, all it needs is a little cut under local and screw can be taken out. Now remember, if you've noticed, it's CMCJ sparing. I have not included CMCJ. The reason being, so this is what we used to do 8 or 10 years back. We used to go through CMCJ. The problem with that is is the capitate and metacarpal third CMCJ, which tends not to fuse up. And other problem is these screws, you can get metacarpal fractures. So, and finally, the advantage is if your CMCJ is free, it gives you 5 to 7 degrees extension and flexion. And once you fuse the wrist, 5 to 7 degrees matters a lot to the patients. So I would not do this almost exclusively now. I will always spare this joint. Yeah, thank you. Any questions?
Thank you, Saurabh, for that fantastic presentation. And it is a very difficult topic that you have made it very, very simple to understand.
Oh, thank you, Dr. Hitesh. Yeah, I've tried to put a lot of SLAC wrist to tell them that SLAC is a common exam case. And you get SLAC 3s and 4s, not 1 and 2. So hopefully, it's not fair. It's sort of when I was giving my exams 8 years back, I know I had not done many dorsal approaches. So it's a bit hard to take in, but hopefully they'll get some.
Okay, so there are some questions, Saurabh, that have come in.
Yeah.
First of all, the moment you say stage 3, that means the capitolunate joint is involved, right?
Yes.
So that is what's your, because I don't think you have put up the slide where we have classified 1, 2, 3, 4. That's Watson classification, if I'm right.
Correct.
Okay, so the moment you say capitolunate joint is involved, then
Yeah.
you think immediately about a capitolunate fusion. That means a four corner or a limited fusion, right? So I think that's the key point, that you do the arthroscopy and look at the capitolunate joint. If it is arthritic, that means you're going to go for a slightly, you need to fuse the capitolunate joint.
Absolutely.
Okay.
So
I think that was the key point in your SLAC and SNAC presentation, isn't it?
Two things. Absolutely. So two things in SLAC and SNAC, as you said, Dr. Hitesh, one is capitolunate joint and the other is radiolunate joint. So if you see in this X-ray, everybody can diagnose this arthritis in radius and scaphoid, i.e. SLAC2. But I do not know if there is a SLAC3 here, and if there is, then is it a SLAC4? So absolutely, to simplify it, scope is about looking at two surfaces, the capitate proximal pole and the radiolunate joint. If radiolunate is gone, your whole wrist is gone, total wrist fusion. If your capitolunate joint is gone, then you have to fuse the four corner fusion, or 3 corner, 2 corner, 4 corner for exam, 4 corner fusion.
And for example, if it is just the scaphoid fossa, that means the radial styloid and the entire part of the scaphoid, that is stage 2, would you just think about doing a proximal row carpectomy?
Absolutely, which is what I kind of mentioned, because then if you do PRC, your capitate proximal pole is pristine. You can easily do that. Equally, you can still do a scaphoid excision 4 corner fusion. The reason being, in young people, you want to keep your carpal height, i.e. 4 corner fusion. In old people, you can do PRC. But for exam purpose, whatever they say, it will be acceptable.
So you would still recommend doing a scaphoid excision and a 4 corner fusion for stage 2, is it?
Yes, absolutely. Absolutely.
And unless it is an elderly patient.
Unless it's an elderly patient.
Do you think the wrist biomechanics is much more preserved by doing a 4 corner fusion than doing a PRC?
Oh, that's a very important question, whether you want to preserve your radiocarpal joint or a mid-carpal joint. I will answer it. So see, our daily activity is like we throw a dart. That's a daily activity, dart throwing motion, like we throw a dart. So what I'm doing as we throw a dart is you're starting from extension and radial deviation, and you're palmar flexing and going to ulnar deviation. This movement happens at mid-carpal joint. So if you have to preserve between the two, a radiocarpal and a mid-carpal, theoretically you should preserve mid-carpal. Practically, there is still a debate between hand surgeons as to is it better or not. So for exam purpose, so for SLAC2, for example, you can even do a radioscapholunate fusion, because my mid-carpal joint was pristine. I've saved my mid-carpal joint, which is theoretically better. But for exam purpose, simple answer, PRC or 4 corner fusion.
I think four corner fusion is a very common procedure that is being done, and I mean, most of the time you'll get bailed out by that.
Exactly, absolutely. Because at their level is not fair. But yeah, if somebody wants to become a hand surgeon, then you have to think about mid-carpal preservation versus radiocarpal. But for exam, very simple answer, which they can.
And yeah, and what about the role of STT fusion? That is again a limited risk fusion for stage 1.
Stage 1 what? SLAC?
Yeah, SLAC.
SLAC or SNAC stage 1, we can just do radial styloidectomy and job done. Like I was showing you, if I can flip some slides, if I can find it there. So see, in SNAC or SLAC stage 1, because this bit of scaphoid has flexed, incongruous joint, if I just excise my radial styloid, so there are no two bare bones rubbing on each other, simple operation. STT fusion is a very hard fusion to achieve, 40-50% of non-union, because you're trying to get scaphoid to fuse to trapezium to trapezoid, lots of surfaces to fuse. So even for STT arthritis, okay, I would do a scaphocapitate fusion, because your trapezium.
There's hardly any role for a STT fusion in today's practice.
Absolutely, absolutely.
Because in case you want to do a limited risk fusion, better to go capitolunate.
Yes, two corner.
If you want to do compare like four corner versus a limited risk fusion, you would prefer, because I saw in one of the pictures you've shown a capitolunate fusion for
Correct.
3.
So what they're saying these days is there, whether you do a four corner fusion or you fuse, this becomes two corner, capitate to lunate, or a third corner is lunate, capitate, and hamate. So they seem to think, again, it's a debate, nobody knows, that if you preserve triquetrum, it helps with deviation, radial ulnar deviations. But again, for exam answer, four corner fusion.
Okay, I think let me go through the other questions. And what about I mean, does the same thing apply to the SNAC? I know you've gone into detail, but see, you know what, this is a slightly difficult area for the exam. So that's why I'm trying to make it more and more clear. So what is the difference in a SLAC and SNAC? Can you explain it in a very simple way? I mean, with the stages.
There is no difference. They are exactly the same. When you read books, stages 1, 2, 3, 4, 1, 2, 3, 4, they have named it a bit different. But let me try and explain to you once more. So for example, okay, SNAC. For example, SNAC. You can see that diagram here, Dr. Hitesh. So there's a fracture there. Now, but let me explain to you SLAC first, because it's easier than to comprehend SNAC. That's what I'm saying. For example, so let's say there was no fracture here. Let's say this is all one scaphoid and the ligament is gone, scapholunate ligament. So what will happen is scaphoid will flex. So at the moment, these two surfaces are congruous. Moment scaphoid flexes, it's an incongruous surface. So scaphoid is incongruous with styloid and with capitate. Incongruity equals arthritis, any joint in the body. So obviously, as I was telling you, the forces start from styloid and comes towards ulnar styloid. So arthritis starts in the styloid. So this becomes SLAC 1. And because whole scaphoid is intact and incongruous, so this will be SLAC 2. And because scaphoid is incongruous with capitate, SLAC 3. Now, if you want, you can say SLAC 4 capitolunate and radiolunate SLAC 5. It doesn't matter. You can name it, you can say ABCDE, doesn't matter. Idea is to understand that arthritis is starting in this way. So what they have done is, to confuse doctors for no reason, they have put this and this as SLAC 3, and then this becomes SLAC 4. You can call it SLAC 5, whatever your classification. So if you now think of scaphoid non-union, this proximal pole is attached to lunate, ligament, scapholunate. So it'll become like a lunate. It is a lunate now. Think like that. So this scaphoid, distal scaphoid, flexes, incongruous. So obviously this will become SNAC 1, incongruous SNAC 2, capitolunate 3, radiolunate 4. So arthritis is going in the same fashion. numbering because they have named it like that, it confuses all the doctors all the time. But important is forces go in this direction, styloid, radial styloid to ulnar styloid. And it is in this direction that perilunate injuries will happen. Obviously, it's a big topic, so I couldn't include it. I didn't want to. It's another 1 hour topic. But wrist biomechanics doesn't change. Hip biomechanics doesn't change. So pattern of arthritis doesn't change.
I think we can remember it in a very simple way. Either the number one is capitolunate joint is not involved. Number two is when capitolunate joint is involved. And number three is when the radiolunate joint is involved. Because treatment purposes, I think that's a very easy way to remember.
Correct. But for staging purpose, because they may ask me the stages.
So because part one is again divided into the styloid and the styloid fossa. Correct.
So easy is to draw this diagram on a piece of paper and explain to the examiner like I have explained with my arrow. I hope doctors could see it.
Yeah, because that's the Mayfield's arc essentially, right? It's almost, great.
These are Mayfield 4 stages, which we discussed before, sort of. I had a picture there, which I showed,
Yeah, I've seen, that's very good picture that everyone should know how the forces pass across the wrist.
Correct, because it bails you out of SLAC, SNAC, perilunate. It makes your life so easy. Otherwise, because I remember giving exams 8 years back, it's so hard. They want me to know wrist and spine and hip. It's not fair. So unless you generalize things, it never comes out at spinal level.
Okay. The other question was, see, there was at one point of time, there was a common criteria that was described when you, like, when do you suspect a scaphoid fracture? For example, you have tenderness in the scaphoid tubercle, you have tenderness in the anatomical snuff box, you have pain on axial compression and pain on the resisted supination. And if you have, say, 3 out of 4 criteria, your chances of having a scaphoid fracture is 90% plus. Does it still hold good? I mean,
I'm not aware of this criteria. All I do is snuff box, tubercle, localized swelling. Axial loading you can do, take a second. If they have swelling, as I was telling you, if a scaphoid is immobilized for 4 weeks, and then you pick up a fracture, non-union is as high as 40, 50, 60%, depending on where the fracture was. So I'll rather, and even for a soft tissue injury, for argument's sake, you're allowed to give a plaster. So you give a plaster, see them in 2 weeks. If they still have pain and x-rays are not conclusive, I'll get an MRI scan. You don't want to sit on a scaphoid fracture without a plaster.
And if it's still undisplaced, you'll just continue with the cast, right?
Yeah. In my practice, undisplaced waist equals a plaster cast for 6 weeks, unless patient is young, working in finance, who wants a surgery and a quick return to work, which will be 1 in 20 waist, if you like.
And you normally put a below elbow cast in neutral position?
Below elbow, Colley's cast. And when you put a Colley's cast, you can rotate. So that won't matter because you can still rotate if it's a below cast.
No, do you put it in neutral or ulnar deviation, radial deviation? It's neutral.
Just neutral is fine.
Okay, and you don't immobilize the thumb?
No, because again, if you're moving thumb, it does create some movement at the scaphoid fracture site, but it's not a big enough movement to delay healing. So that is why there's no need to include thumb.
And if I'm right, you said that in a proximal pole, you would like to put the cast for 3 months.
Up to 3 months.
Up to 3 months. So would you like to repeat the X-ray after 2 months and then plan, or how do you go about if it's a
scaphoid, 2/3 scaphoid is covered with cartilage, so the healing is endosteal, not periosteal. So problem is even at 3 months, looking at the X-rays, I'm not sure if healing has happened or not. But if clinically patient is non-tender, I'm happy. And proximal pole, I'll see them, the last follow-up is at 1 year. And clinically, if patient is tender at 3 months, I'll get a CT scan.
And generally for the approaches for non-union, you go Volar for all the non-union except the proximal pole, right?
So waist, whether it's an acute fracture or a non-union, as you said, you have to go Volar. The reason being, if I can bring up that humpback slide.
I'm just trying to recap so everyone goes home with a solid message.
It's very important because if you see humpback, unless you go volar, you cannot correct it. If you go from the back, you can't correct the humpback. So you have to go volar, you have to correct it. This is a normal orientation. Then you hold it with a wire, like here, wire, under X-rays. Once you're happy, then you pack it up with graft. So waist, always volar. Proximal pole, always dorsal. I just told you humpback you can't correct from dorsal, but proximal poles are stable. They don't get humpbacks.
Humpbacks. So that's a very important point that you mentioned, that proximal pole is
Correct.
a stable configuration.
Yes,
And,
because in proximal pole,
and if it's proximal pole avian?
avian, again, mild, moderate avian doesn't bother me. I'll do a simple distal radius graft and a screw. If it's very fragmented, then either you do scaphoid excision for corner fusion, or these days you can replace APSI, those pyrocarbons, you can replace them, but we don't need to do that for the
What
exam.
about the vascularized bone graft? The
Yes.
artery?
Again, see, some surgeons say it's a surgical stunt. Some people don't believe in that. Some surgeons very occasionally will do a vascularized graft. I have never seen one, not done one, even though I was at King's Polytrauma Center for 3 years. So it's a very, very rare surgery. You will not see fragmentation in proximal poles, very occasionally. If I see one in 3 years, it's not fair on me to operate. Then I'll send it to a hand surgeon who does a bit more. So in the exam, yes, you have to mention vascularized graft, but you have to just cram 1, 2 interretinacular artery or something, and you just say them, and they will not grill you further, because even I do such high volume of handwork, I would not do a vascularized graft. Some surgeons even say it's a surgical stunt. It has no sort of benefit.
Yeah. Carlos Zeidenberg, I think that's from the Carlos Zeidenberg, based in South America.
Absolutely.
I think there are no more questions, Saurabh, and that was a fantastic lecture from your side. Your lectures have been really good. I could see them the way they're being shared online. The first lectures like seen by a lot of people, and I'm sure this is going to be yet another similar lecture. Thank you so much for your valuable time and the effort that you take to teach the candidates who are appearing for the exam.
Thank you for your kind words. I think take-home message is that forced transmission. Because unless you appreciate that SLAC, SNAC, Lunate is a very hard topic to comprehend. So I would just tell all the doctors, draw the wrist bones on a piece of paper. And then let me just try and bring that. Where is it now? Sorry, I think it's gone. But draw those bones on a piece of paper. You should know anyway how a wrist X-ray should look like. You can be asked to draw a wrist X-ray, you know. So this X-ray on a piece of paper, and then think how forces travel, and it'll be easy.
I think it's called as a link concept or something, no? Is it the link
Yes.
of?
If you go into wrist biomechanics, yes, link concept, you need to know axial loading through radius and ulna, you need to know how distal row. So see, distal row behaves as one. Proximal row doesn't. That's why for STT, if I fuse scaphoid to capitate, in a way I'm fusing scaphoid to all the 4 bones. So that's why STT fusion should not exist. It should be scaphocapitate. So there's lots to think in wrist, but for simplicity, idea is SLAC SNAC. Idea is scope it, not MRA it, for staging it. Idea is 4 corner fusions, maybe PRC, maybe total wrist fusions. Job done. It's as simple. And dorsal approach, 3 steps, which I told them last time and this time also, just 3 steps. How you save your cutaneous nerve, how you cut your retinaculum, how you cut your flap capsule, how you cut your cap, three stages. And that's it. That's all they expect of you. No point saying, I'll position the patient, then I'll cut skin, then I'll take away fat. That's wasting time. I need to know those 3 steps. I need to like get the knowledge out of a candidate.
Thank you, Saurabh. Once again, I'm sure if I allowed you to speak for another half an hour, you just continue. That's your passion. Really appreciate that, and looking forward for more lectures from your side. So we'll sign off for right now, and we'll get back once again later.
Once again, good luck, guys. Thank you for your attention. Thank you, Dr. Hitesh. Thank you.